Dear colleagues, dear resident and young neurosurgeon, it's a pleasure for me to be here. Thank you to be present. My talk is about the spine, cervical spine trauma. As you know, the craniovertebral junction is a complex and also ligamentous region that incorporates the occiput and C1 and C2 portion of the spine. It's a transition zone between the cranium and mobile cervical spine that permit significant motion, that balance maximum stability and protection of vital neurovascular anatomy with ample mobility and range of motion. Full characterization of it with injuries require an accurate history, physical examination, and good comprehension of radiographic projection of the craniocervical junction. The educational objectives are to classify the upper cervical spine trauma, to describe the radiographic criteria of instability, and describe the most accepted classification for the different types of craniovertebral junction trauma. Referring to the classification, we will adopt the following plan. First, we see the isolated ligamentous injuries after isolated bone fracture, and we finish with ligamentous and bony injuries. The first is atlanto-occipital dislocation. It's the most severe type of injury of the craniovertebral junction. It's found in 10% of all fatal cervical injuries and represents more than 30% of motor vehicle accidents in fatal cases. They are usually caused by high velocity accidents, and children are often exposed. The mechanism can be hyperextension, hyperflexion, or lateral flexion. 70% of cases can be accompanied by brain and spinal cord injury and severe neurological deficit. They are highly unstable, compress, and distort the spinal cord. The delay in surgery treatment can cause a significant increase in neurological defect up to development of a fatal. Plain radiographic measurement technique may be used to detect dislocation of the craniovertebral junction. This method assesses the relationship between the skull base and cervical spine on lateral radiogram. These methods are recognized line, the power lines ratio, the basio-dental interval, and Dublin's method. This method can be applied to find instability of atlanto-occipital dislocation. The recognized lines extend caudally along the posterior surface of the clavius. This line should be tangential to the posterior type of the dents, and if the occiput is displaced anteriorly, the line will intersect the dents, and if the occiput is detracted or displaced posteriorly, the line will be separate from the type of the dents. Traditionally, this technique has been used to assess basilar invagination, but can provide a general assessment for dislocation. The second measurement is power ratio assess. The relationship of two lines is the distance between the basion and the posterior arc of C1, and between the opisthyon and the anterior arc of C1. In normal individual, basic average is 1.77, and a ratio more than 1 is fairly reliable diagnostic indicator of anterior dislocation. The third is the Woolley Bayesian dance method measurement. It measures the interval between the Bayesian and the type of the dent in the neutral position. In adults, the distance average 9 millimeters, but varies considerably, and any motion between these landmarks on dynamic radiography is abnormal. A distance more than 15 millimeters in adults or 12 millimeters in children is abnormal. The last one is the Dublin method, which measures the distance from the posterior cortex of the ramus of the mandible to the anterior portion of C1 and C2. The second ligamentous injury is the transverse ligamentous disruption. This lesion is an instable injury. Mechanism can be a hyperflexion. Okay, the diagnosis can be made on islet lateral view and can show a translation between C1 and C2 of more than 3 millimeters in adults and 5 millimeters in children. The MRI imaging show a high signal intensity which confirm anterior ligament transverse disruption, and the CT imaging confirm a fracture of the tubercle of C1, which means instability. We talk about it in the fracture of Atlas. The first isolated bone fracture is the occipital condyle fracture. They are only seen with high energy mechanism. They occur with axial trauma. They are almost always unilateral on 19%. The diagnosis is based on CT imaging with reconstruction view to establish the occipital condyle fracture. MRI is recommended to assess the integrity of the craniocervical ligament for determining the stability of occipital condyle fracture. Usually, open mouth radiographs have low sensibility. The most widely classification known for this lesion is Anderson and Montesano classification, which entails a gradation of increased severity. It goes to type 1 to 3, and this classification is has been more recently modified by the classification of Choli, but the two previous classifications are mainly academic interests, as they contribute marginally to clinical decision-making process. There is a new classification system by Müller, which is more useful in the treatment algorithm of this lesion. This is the algorithm with according Müller classification with surgery indication in the type 3. The second isolated bone fracture is Atlas fracture. As you know, Atlas or C1 is an integral and crucial part of craniovertebral junction and acts as transitional structure between occipital and cervical spine. C1 fracture accounts for 25% of all craniovertebral junction trauma. They occur as a result of motor vehicle accident in 85% of time. C1 fractures are most often a result of an axial load plus an additional vector of compressive force. And they are associated with 40% to 44% of C1 fracture. The cervical spine X-ray remain the first line diagnosis tools to identify isolated atlas fracture. The management of this fracture is based on the integrity of the transverse ligament that can be accessed indirectly with several radiological measurements. The sum of lateral mass displacement of C1 over C2 more than 7 mm in open mouth X-ray mean transverse ligament probably damaged. This is the rule of Spence. Measurement over this number denote a rupture of the ligament transverse and accessory stabilization ligamentous. MRI is a more sensitive indicator of ligament transverse integrity or disruption than the rule of Spence. CT is always necessary to evaluate the integrity of the atlas rings and to classify fracture between stable and unstable burst fracture. Concerning the classification, the Jefferson classification relates the mechanism of injury with the type of fracture, whereas the Dickman classification focuses on integrity of the transverse ligamentous and degree of dislocation of the bony avulsion fragment from the lateral mass, which is important to define surgical treatment option. However, Buehler classification, because it integrates categories of previous classification, is far more useful for treatment decision. This is the algorithm for atlas fracture according to Buehler classification. As you see, the type 3B is surgery is recommended for this type. Now the odontoid fracture, they are the most common fracture of the axis. Most fractures present without neurological deficit due to the ample anteroposterior diameter of the cervical spine canal. They are diagnosis based by location of the fracture line, which is most easily visualized on coronal CT reconstruction. The common system of classification was developed by Anderson and D'Alonso in 1974, which include 3 types, and the type 2 is the most commonly. In this type 2, the fracture occur at the junction of the odontoid process with the body. In 2005, Lorenz proposed a modified classification system of odontoid fracture to help head in fracture management, and the system modified and redefined Anderson and D'Alonso type 2 and 3 odontoid fracture subtypes. According to this classification, which adapt Anderson and Alonso classification. The type 2B and 2C are indicated for surgery. Now the hangman fracture is the bilateral of axis sparse interarticular fracture who was first described by Hampton in 1816. Most traumatic hangman fracture are a result of fall or motor vehicle accident, and the injury mechanism typically involve an hyperextension and compression insult. Only 9% were associated with fracture of atlas, and additional 9% were associated with fracture of subaxial spine. Diagnosis of hangman fracture. In the diagnosis, radiographic plans are useful in studying alignment, but are far less sensitive than the CT imaging for evaluation of the fracture. According to the classification, FND and R-based classification is based on its array and clinical course, and this classification has been modified by Levin based on the mechanism of injury. This is the FND classification, and here modified by Levin and Edouard. And this algorithm with for the hangman fracture, according to Levin, FND and Levin, with surgery indicated in the type 2. The last type of lesion is a combination atlas and axis fracture. They are relatively common, and they are account for 44% of all C1 fracture and 16% of all C2 fracture. The rate of neurological injury are superior to isolated CN or C1 or C2 fracture. The rate of non-operated fracture is superior in C1 or C1 and C2 or C2 fracture. The diagnosis need combination plain radiography, CT imaging, and also MRI finding. The classification of Digman, according to this classification, surgery strategy can be made with surgery for the type 3, which are unstable. For finish recommendation, cervical CT with sagittal and coronal reconstruction plays an essential role in diagnosis and surgical planning of as first-line study. MRI is crucial to assess the integrity of craniocervical ligament, like transverse ligament. Allovenous immobilization is associated with increased morbidity, especially in older patients, and surgery is indicated in unstable fracture. For surgery, the hangman fracture, Levin 2R and Levin type 3 require posterior surgery or anterior or posterior surgery, and when there is C2 or C3 disc injection, anterior surgery is recommended. For failure and intolerance to external allovenous immobilization and established non-union associated with instability are recommended for surgery. Thank you for your attention. The next speaker is Amir.